5. Be careful judging a book by its cover, because if you do, you may miss a really interesting story. So this applies to the speaker I'm going to introduce today, Dr. Nasser Lakkis. It is my pleasure and my honor to introduce him. And on the cover, here's what I'm supposed to tell you. He went to medical school and did his residency at the American University of Beirut. He did his finished his fellowship, his residency in medicine, fellowship in cardiology, additional fellowship in cardiology, interventional cardiology at Baylor College of Medicine. He won so many excellence in teaching and outstanding educator awards. They retired the award just so somebody else could win. When he went to Wayne State in 2022, he immediately received the Outstanding Educator Award, and he is now the Andrea A. Mitchell Chair of Medicine at the University of South Alabama. That's the cover. So what's not on the cover of this person I have known? Oh, let's just say I met him when I was 10, so about 2 decades. Nasser Lakkis is a tremendous educator. In the time I've known him, I would say you've trained over 200 fellows. We never lost one. He procured so much grant money while doing his clinical work that I got in trouble with the ACGME every year because they said I was supposed to pay a certain percentage of every fellowship director's salary, and I couldn't pay him because there was just too much money involved. I can tell you that when he finished his fellowship, he was recruited by the finest private hospitals in the city, and he chose to go to Harris Health and work at Ben Taub. There, he built a cardiology service that the patient satisfaction and the clinical evaluation metrics rival that of Methodist and Texas Heart. And I can tell you that more than once when he was not on call and didn't have a room, we caught him sleeping in his car because he wanted to be close to a patient he felt was in need. So that's the part of today's speaker that is beyond the cover of the book. And at this point, I'm going to turn the mic over to Dr. Nasser Lakkis.
Dr. Levesque, thank you so much. This is very generous of you. I'm so honored to be here back in my hometown. And it's so great to see a lot of people who I know over the years at Baylor and in Houston. So again, thank you for the invitation. My talk today is to talk about quality in healthcare. I think this is a topic that not too many people address. I think we take it for granted. Most of us assume that we provide quality care to our patients. And sometimes it's hard to measure basically that quality. When we get to be screened and evaluated, invariably gaps are found. And that's why this topic has become a hot commodity at this point. And many institutions in the country are lasering in on quality, for the least of which is that CMS actually is paying a lot of attention to it. In addition, the ACGME and the LCME are also very concerned about quality of care. I put this slide up for an obvious reason. To talk about quality, there are so many dimensions to quality and so many attributes to it. It's very hard to define it, despite all the attempts that have been put so forth to define quality. So it's a very complex topic, and I'll try to dissect it into its elements as much as possible. I hope some of the material will not be boring because it's a topic that requires of us to kind of be more systematic in the way we address it. This slide here sums up what comes out sometimes in the newspapers regarding blunders in healthcare. This is taken from European Journal. Surgeons operate on the wrong organs in 19 cases. Some money is paid for hospitals because patients died from dehydration while in-house, or the waiting list in a hospital is so long that patient care is delayed. So these are all elements that quality assesses usually when you look at a program or a hospital. In the US, the scope of medical errors is actually quite concerning. In 1999, I'd say that 98,000 patients died from medical errors. It's assumed that almost 1 in 100,000 patients have adverse effects or death from medical treatment errors. And there are 2.5 million people in 2017 that had hospital-acquired conditions. The readmission rate overall in the US in all hospitals is 13.9%, which is way above the 5% that CMS actually has set for all of us. So, putting things together, preventable medical errors in the hospital setting exceed death from car accidents, from breast cancer, and AIDS altogether. The definition of medical error is the failure of a planned action to be completed as intended or the use of wrong plan to achieve it. Usually these errors occur most commonly in the emergency department, operating room, and the ICU. Examples of those errors are surgical or interventional injuries, meaning that the patient undergoes a interventional procedure, for example, and they die from a bleed, or wrong site surgery, suicides in the hospital that's not been attended to, adverse drug events, or wrong drugs given to patients, improper transfusions, specifically mismatches, restraint-related issues, falls, pressure ulcers, and mistaken patient identities. All of these elements can contribute to medical errors in the hospital setting. These errors, when they happen, they're quite costly. It's estimated that the cost of, besides human lives, the monetary cost ranges between 17 billion and 29 billion a year to correct these medical errors. There are also legal implications to it. There is prolonged illness, repeat visits, and obviously possible death. When those things happen and the word start going around in the hospital system, obviously the morale of the staff would go down, and there'd be a lot of turnovers in staff. And that usually reflect on the quality of staff in a particular healthcare system. Now, the National Healthcare Quality Report is mandated by the US Congress to focus on national trends and the quality of healthcare provided to the American people. It uses measures to track the state of healthcare and address three questions. Have things improved? What else needs to be worked on? And are there any disparities in care? The story started back in probably in the late 1800s with Dr. Ernest Codman. He's actually the first physician who started to self-evaluate quality of care provided to patients. He kept cards on all of his patients. He recorded their symptoms, their clinical diagnosis, the treatment plans, complications, and then followed up on these issues yearly after the patients had an encounter with him. Obviously, back in the late 1800s, he faced a lot of opposition from his colleagues and the hospital system. They looked at it as a method to kind of expose him, if you will. But then the American College of Surgeons adopted his method to track quality of care to patients in 1916. And the Joint Commission established an award to recognize him in 1996. Now, how do you define the quality of care? I gave you examples before, but there are at least a couple of definitions that we agree on. The Institute of Medicine defines quality of healthcare as the degree to which healthcare services for individuals and populations increase the likelihood of a desired health outcome and are consistent with their current professional knowledge. The foundation of quality healthcare defines quality in healthcare as doing the right thing at the right time, in the right way, for the right person, and having the best results possible, avoiding overuse, underuse, or misuse. I think this is a very straightforward definition. It's intuitive, but it's not as easy to apply as it sounds. Now, over the years, some domains of healthcare quality have been defined. We all agree that healthcare has to be safe to avoid harm to patients and provide them with the care intended to help them. It has to be effective, meaning that we provide treatment that it changes the outcome of patients. It has to be patient-centered, that also addresses patient preferences, their values, and ensure that the patient values guide the clinical decisions. It has to be timely. Many hospitals suffer from having a long wait time for patients to undergo treatment plans, more so in Europe and Canada than here, but definitely we have some bottlenecks in this country also. It has to be efficient, have to avoid waste, including waste of equipment, supplies, and energy. Doing the same procedure using, for example, from my standpoint, if you do a PCI, if you use 10 balloons and 10 wires to open up one artery, that is actually misuse of equipment and supplies. It has to be equitable also. It has to provide care that doesn't vary in quality because of personal characteristics, gender, ethnicity, location, and socioeconomic status. An example of that is some states actually allow residents and fellows to supervise patient care independently, completely. I know the ACGME requires for residents to have panels, but then without any attending supervision. And patients tend to be referred to residents and fellows if they happen to have no insurance or they come from low socioeconomic class, and they go to an attending physician if they're more resourced. And that's the equity that we all actually try to work on. Now, what are quality measures? So we all talk about quality measures. How do we measure quality? These are measures that are based on evidence generated through research and clinical practice, mostly beginning with clinical guidelines. For example, let's say STEMI guidelines. We all know that the door-to-balloon time has to be less than 90 minutes. We all know that patients should receive an aspirin when they hit the emergency department. They all should be sent to rehab after they have a STEMI. So all of these guideline recommendations start the quality measures that some hospital system put in place. Similarly for sepsis, the time it takes for a patient to be placed on antibiotics when they hit the emergency department, or identification of pulmonary embolus and treating patients appropriately. So these are the measures that hospitals put in place that are based on guidelines and recommendations. Then quality assurance is to make sure that the system is well equipped to provide safe and accurate care to these patients. And things that we all pay attention to in a hospital system: hand hygiene, protective gear, needle safety, isolation, anti-skid floors, look-alike and sound-alike medications. When you have two medicines that have similar names and somebody gets confused and they give the wrong medicine to the wrong patient, expired medications, dosing errors, verbal orders that are not cleared or clarified, labeling of medications, handovers, which is a big thing for a clear of the ACGME. Basically, they want to make sure that the handover process is safe, and wrong site surgeries. So these are quality assurance measures versus the quality measures themselves. We do all of these things to avoid things of this sort. You have a cardiac patient, it doesn't have to be a flip of a coin to decide if you want to give them an aspirin or send them to bypass. You should have better parameters to make decisions on patient care. Now, who's responsible for quality in healthcare? Obviously, patients are the ones who relate their improvement to competence of the institution they go to. And also, they are cost conscious, so that factors into quality. Clinicians' competence, professional knowledge, certifications, all of them are elements that clinicians have to meet to provide quality care, or a minimal standard, if you will. Administrators, by achieving organization-wide goals for safety and quality, including having a strong risk management office in a hospital system. The government, we all know that publicly funded healthcare programs such as Medicare has certain parameters put in place to ensure quality. The most common ones that we all are aware of, like length of stay in the hospital, for example. And then there's the hospital compare, which compare actually outcomes in different healthcare systems where Medicare patients go to. And any one of us can go and check and determine where your institution actually falls in terms of quality among the rest of the hospitals in the country. Then you have the guidelines from professional societies. You have different societies publish and update the guidelines routinely to make sure that practitioners are practicing up-to-date medicine. And the payers basically dictate the effectiveness and the efficiency of care provided. Sometimes they overdo it, they overshoot by limiting access to certain procedures or certain testing, but also they have their own databases that justify their decisions too. As I mentioned before, from a hospital regulatory approach to quality, risk management is a big thing that most hospitals put in place. It's a proactive effort to prevent adverse events related to clinical care and facilities operations. What else is put in a hospital system to look over quality? A peer review process where events are evaluated and physicians are evaluated by experts or colleagues. Obviously, the Mortality and Morbidity Conference, which I'll get into in a second, it's a requirement by ACGME now. Root cause analysis, where whether the system error, if you will, that led into poor outcome or less than a quality byproduct. Root cause analysis analyzes the system, analyzes the hospitals, analyzes physicians, nurses, all of them are included in that analysis. And then if you identify a physician that lacks competency in certain areas that they participate in patient care in, you place physicians on performance improvement plans with set goals for these physicians. Once they achieve these goals, they can potentially be put back in the field to take care of patients. This is a statement just to kind of highlight the difference between perception and reality when it comes to quality care. All of us, I think maybe 99% of physicians, assume that we actually provide superior quality care day in, day out to all of our patients. This is, one of the CEOs of a hospital system says, prior to accreditation of a particular area, we believed we were treating ACS patients the best we could. Our processes were up to date. Our time assignments for each step were accurate. And our communication with the patient and their family was optimal. But we discovered there were many opportunities for improvement, and not all patients were receiving the standard of care all the time. So you may actually be providing the standard of care in 90% of the cases, and 80% of the cases. When you look at all the cases, you realize not all patients are receiving the same standard of care in a timely manner. So quality measures help demonstrate gaps in clinical practice, evaluate process improvement areas, and create benchmarks to improve outcomes. Great example of that, perception versus reality. So if you look at STEMI patients, this is a known fact, this is from the ACC. If a patient has a STEMI in-house, their door-to-balloon time is actually prolonged about a third of the time, up to double the time, compared to patients who walk in from home or being brought in by EMS for their door-to-balloon time. So it takes longer to make the diagnosis of STEMI in a hospital, to call the physicians, the right people, get the ECGs, page, call. The system is not actually put in place to treat inpatient STEMI patients. It's put in place in most institutions to treat patients who are coming through the emergency department. I've seen it day in, day out in my own practice, and we worked on it. We put actually a protocol for inpatient STEMIs for people to follow, because we were among the same boat, basically, realizing that STEMI patients, if the STEMI happens in-house, there is delay in care. And who would have thought that if you have a STEMI in-house, that your door-to-balloon time is 129 minutes on average versus 60 minutes if you came from home. That's why quality metrics and quality measures help you identify these gaps. Would have never known, would have always assumed that we're great until you look. Then how do you improve quality? I mean, obviously, transparency is the first thing. You have to share information. The information has to be accurate, and people have to be comfortable to share the information with each other. You have to be professional. You have to be ethical about, the data and the practice that you're in. It has to be evidence-based. Hopefully it's non-punitive. Hopefully it's only put in place to improve the system and improve quality, but not to point fingers at people and practitioners. There should be some accountability. It is everyone's business. It is the physicians, the nurses, the administrators, the leaders. Everybody must participate in improving quality. And it has to be put in a way that's sustainable. That, if I leave or the CEO leaves or the administrator leaves, that the system will carry on after, one particular person who put the metrics in place decides to leave. So how do you do that? How do you put these essential elements in place? There are three elements, if you will, for establishing quality care in an institution. There are structural issues, there's a process issue, and there's outcome tracking. So what are the structural measures? Structural measures are how fit is the system that you work in to track quality? How's your medical record? How's the entry system? How comprehensive is the data in that system? Then also you look at how many board certified physicians are providing care for this particular item that you're trying to track. The ratio of providers to patients. If you have more patients than providers, then you're bound to have a lack of timeliness in providing care to patients. What's the expertise? Do you have diverse expertise and skill of the providers? Do you have the modern equipment so you can get good outcomes? And the capacity of the hospital. Is it that you go on drive-by, for example, after you have 5 patients needing a certain type of care? So all of these elements, dictate quality. If you don't have a capacity in the system, you don't have enough providers, you don't have a good ratio of patients to physicians, you're bound actually to fail. So this is what you look in a structural way. Now, the process that's put in place are these protocols that many of us have put in place in different hospital systems. Let's say pre-hospital algorithms, like now instead of, I'll use a cardiac example because I'm quite familiar with them. Instead of talking door to balloon time, now we're talking about first medical contact to balloon time. When the EMS picks up that patient, the clock starts then because the STEMI already started. It's not when they hit the emergency department. And if you look at aspirin post-MI, look at LVEF evaluation, look at DAPT after you put a stent, look at risk-adjusted bleeding to decide on appropriate medications, time out, consent forms, all of these things, are put in place. So all the healthcare quality measures that we put in place, this is what's reported out in any system. So all of these measure quality items that you list in a hospital care system, this is how you get compared to different institutions. Now, how do you measure your outcome? I mean, obviously, you put these systems in place, you put the processes in place, then you have to measure the impact of these processes on patients' outcome. You look at, let's say, mortality at 30 days. You look at complications from a particular approach. Let's say you're implanting pacemakers. You look at the incidence of pneumothorax after pacemaker placement, excessive radiation, excessive contrast use. If you open up a blocked artery, but you use 6 times the allowed volume of contrast, you're basically shutting down someone's kidneys. You open the artery, but you put them in renal failure. Or if you expose them to excessive radiation and so on. So, or, God forbid, you open up a vessel and then you have a retroperitoneal bleed that leads to patient's demise. So these are the outcomes that you measure after you put these processes in place. Readmission rate is a big item. In heart failure, readmission rate is a big item that CMS actually tracks. And the functional status of the patient after discharge. Yes, you opened up the artery, but the patient went to rehab, or patient went to a nursing home, or patient went to a long-term facility. Is that good medicine or not? So all of these items would be outcome measures that one would look at. So, how do you collect this data? I mean, this is a bit of a detailed slide, but just I want to highlight how this data is collected to be compared. You have the administrative databases, which is based on billing, and usually these forms are short and not too comprehensive, but they're one source at least to know who came in, if you will. Medical records, obviously, they're rich with data, but it's not put in place in the same format in all patients. So it takes some effort to kind of put all of this data in one unified format. Patient surveys, patients are the best proponents or opponents of what you do. When patients get surveyed, they either praise you or they said, please don't ever take me or a family member to this place. And patients' comments online and things of that sort. Also, these are things that are used for quality. Like it or hate it, that's what's happening these days. All right, so in order to have meaningful data, you have to standardize. The elements have to be comparable. It has to be timely. I can't report on 5 years ago today. I have to report this year what I did this year. It has to be relevant. It has to be valid. Also, you have to be comfortable that this material is credible, if you will. So all of these elements would make the quality measures that you put in place comparable, valid, and can be evaluated, if you will, and distinct. Now, if you're a hospital care system, how do you put a framework for a quality measure in place? You have to identify the issue at hand. You have to get key stakeholders to buy into what you're trying to do. And then you have to put some implementation methods and metrics and a time frame to track. So you have to identify, you have to bring your stakeholders in the same table, and then you have to implement. You have to kind of put the time frame, the metrics, methodology, how you're tracking all of these things. Examples of common quality measures. I mean, obviously, in terms comes to diabetes, A1C control, diabetic eye exams, LDL control, blood pressure control, diabetic education, all of these are examples of quality measures. In CAD, aspirin use, testing. In CHF, following the guidelines. In STEMI, as I mentioned before, door to balloon time, DAPT, prescription of medications after stenting. You do not want to put a stent in somebody and not make sure that they got their DAPT after they left the hospital. You know, what good is that? Bleeding complications, contrast use, and then the preventive things, you know, mammograms, depression assessment. We just had this session with Dr. Reed today. And these are the elements that, you know, we also look at in terms of preventive measures. Are they put in place? Is every physician following the guidelines? You know, you can read basically the rest of the list, and the list has about 120 items actually to track. So, you know, I kind of covered this in a way. I'm gonna move on, not to bore you too much. So cardiovascular quality measures have been in place for a while, and you know, they have proven over time that they can improve outcome, reduce mortality, improve readmission rates. There is a format or a forum for public reporting, and also pay for performance, specifically in heart failure, is put in place already. Let me use heart failure as an opportunity here for us to show an example of how you can put heart failure metrics, put them in place to improve quality of heart failure in the healthcare system. So 6 million Americans live with heart failure today. The cost of it is about $20 billion at this time. Admissions for heart failure cost the US about $1 billion a year. So it's a very expensive, it's the most common DRG for admissions in any hospital care system is heart failure. Give you an example. This particular person, e.g., is a 34-year-old male, history of chronic heart failure, reduced ejection fraction, EF 15%, diagnosed in 2016, obstructive sleep apnea, post-substance abuse, non-insulin dependent diabetic, hypertension, possible psychiatric illness, and 22 EC and 16 inpatient admissions for acute exacerbation of heart failure in the past 10 months. So this is a real patient taken from actually an institution that I'm aware of. Okay, so look at this. I mean, this particular case highlights the importance of putting some quality metrics in place to prevent, you know, these situations. So in the same system where that patient showed up, there was an attempt to put some structural measures for heart failure in place. So let's see if we can apply the evidence-based pathway for care for heart failure. Let's put some mechanisms to monitor patients in outpatient situations. Let's see if we have a place where these patients can be referred to if they require a higher level of care, such as transplant and so on. And or if someone is end stage, let's put some end-of-life discussions with these patients. So the process measures for heart failure, we identified the problem. What's the process? To initiate guideline recommended metrics, apply clinical trial data into these patients, identify obstacles that will stand in the way from using guideline-directed medical therapy for these patients. What are the obstacles in this particular system? And track patients horizontally, basically, in the inpatient and outpatient setting. The outcome measures, medication compliance, readmission at 30 days, mortality, and whether these patients have had a cardiologist take a look at them or not. So in any system, and this particular system I'm using as an example, we collaborated with the American Heart Association. They have the Get With The Guidelines for heart failure. It helps hospitals to provide defect-free guideline recommended treatment to admitted heart failure patients and reduce avoidable 30-day readmissions in these patients. Participating hospitals will benefit from a no-cost patient education resources, including digital and mobile-friendly tools. So you give them basically pamphlets, if you will, and then iPads are made available to patients in-house where they can learn about heart failure while they're being admitted. So 700 hospitals participate in Get With The Guidelines for heart failure. And the institutions who participate and succeed, they'll be awarded, they'll be recognized, if you will, by the AHA at the national level. And the name of the institution will be placed in the US News and World Report as a bronze if you do it well for 1 year, silver the year after, and then you become gold and gold plus if you maintain that success. And this is published nationwide. So you can choose what points you what the processes you wanna actually include in your achievement measures. Let's say wanna comply with the guidelines, the guideline-directed medical therapy. We're gonna make sure every patient has an assessment of their left ventricular ejection fraction. Look for reversible causes, such as ischemic heart disease, such as amyloidosis, things of that sort. And make sure that these patients have good follow-up when they leave the hospital. There are more things that you can look at. You can look at, if they had AFib, if they receive anticoagulation, DVT prophylaxis, if they got resynchronization therapy, vaccinations, and phone calls can be given to patients at 48 hours to make sure they're receiving their medication or receive their medications, they're taking the medicines, they're compliant with them, they have had no side effects from it, and ensure a follow-up visit for these patients. Okay, so what the system decided to do, executives, internal medicine physicians, cardiologists sat down and decided that we're going to actually implement this measure for heart failure and to improve on outcomes, if you will. The system decided every admitted heart failure patient would have an automatic consult to a cardiologist to see him just one time to ensure that their diagnosis is accurate and they are put on the GDMT recommended therapy. Pharmacists consulted to educate patients on their medications and side effects of what to look for, and a referral to transition of care so patient would have an appointment with the primary care physician when they leave. We also did 1 hour education for the patients in their rooms. They get an iPad and they read about heart failure, they understand what to look for. They get a phone call at 48 hours to make sure they're home, safe, doing well. Many of you have seen the papers that we give to patients with heart failure that has red, yellow, and green. If you're in the green box, you're doing well, you're taking your medications, you're compliant, your shortness of breath hasn't worsened, you may have improved, your exercise tolerance has improved. Yellow, you started to gain weight, you started to get a bit short-winded. Red, you gained 5 pounds and you get more short-winded. So patients know when they are in the red category, they call the clinic and they come to be seen, or they call the physician's office. So patients, before they left the hospital, they were given an assured appointment in the cardiology clinic also. Like I said, we had the smart phrase. We educated the physicians, educated the nurses, and then we had an independent person from the AHA come in and abstract material information on these patients from the charts. So it's an independent, objective person abstracting the data from the charts. Wasn't the physician, wasn't the nurses, wasn't the administrators, not the insurance companies, just an independent person who works with the AHA came in and abstracted the data from the charts. Obviously, we continued meetings with the internal medicine folks, with the AHA folks, nurses education. We required a module for nurses to learn about heart failure, to be retaken every 6 months. Try to cohort patients in the same unit where you have the same nurses taking care of this particular category of patients. If someone didn't show up to clinic, we call him and advise him to come back. And then we have an open policy in the clinic. You can show up in the clinic if you're not feeling well. Someone will see you, will take care of you. So here, how close are we to get into compliance, right? It's either you fall deep or you make a nice jump and then you have some improvement that is detectable. So this is actual data collected between 2017 and 2018. If you look at the percent of patients consulted before the dashed line where we implemented this program, you see there's definitely an increase in the consultations to cardiology over time. If you look at the compliance with beta blockers, again, the trend was almost consistently higher. If you look at ACE or ARNI, which is indicated for heart failure, most patients met that metric. And you see, it's a process. You know, sometimes you dip, and then you learn from that, and you go back. LV function measurement, everybody loves echoes. Everyone got an echo. Then if you look at the follow-up appointment, that's the biggest success that we had in terms of ensuring that patients have a good follow-up appointment. But what really made a difference when we had all of these measures put in place, the readmission rate dropped significantly from what it was about 19% to about 13%. And then eventually, I don't have the slide for it, we could continued to drop until we went down to about 7%. So we hovered between 7 and 10% consistently while that program was in place. So when you track quality in healthcare, what you gain is, regulation. You get certified. AHA would certify you as a heart failure center. You get accredited. You get basically high grades when you're compared to other systems. And then you may get a quality award too with it that, you can put a panel on the highway, say Hospital X is, recognized by the US News and World Report as a hub for heart failure care. And that may bring you patients if you're interested in business also. So like I said, you get the awards, you get recognized, you get, mentioned the US News and World Report, and then, news briefs, they put your name somewhere. I erased the names of other people I didn't consent that were included here. They mention you as if you're a hero and so on. So you get even some personal, boost to what you're doing by being mentioned in many places. And then you get accredited by the ACC and the AHA. And then if you do it for heart failure, do it for AFib, do it for CAD, do it for STEMI, then you become a comprehensive heart center. And then once you claim that, then again, your visibility would definitely improve significantly. Let me switch gears a little bit. So this is at the hospital level. How about quality of medical education in terms of GME and UME? Obviously, the GME and UME are extremely interested in making sure that residents and students are aware of quality measures, quality metrics, and they want them to participate actively in these quality measures that hospitals and medical schools put in place. So we all know that M&Ms are required by the ACGME. In 1983, they made it a mandate that every training program must have M&M. And they also put some more guidelines in terms of making residents understand that their actions, are part of a larger system. And they want to, help encourage residents to identify system errors so they can be corrected and adjusted, if you will. So now, quality measurement and evaluation of errors, and Dr. Levesque, I'm sure you do it day in, day out. It's part of a modern program requirement. I mean, the residents have to participate in quality improvement. So these programs, obviously, the common program requirements of the ACGME stresses quality, CLEAR, which is also clinical learning environment review that residency programs go through. I'm going to show you a slide on it, what they look for to make sure that the training program is compliant. And the milestone project also look at quality. A core training statement that's put by the ACGME to make sure that residents provide quality care and participate in quality measures in a hospital care system. So what CLEAR, the Clinical Learning Environment Review, it's an opportunity basically for this particular entity to provide a reviewed focus, if you will, or focused review, I should say, on 6 areas, which is patient safety, healthcare quality, care transition, which is a big deal, I remember first time Clear made a visit, actually, that we were so shunned, if you will, because we didn't have a clear transition of care of patients, between the day shift and the night shift. And even the nursing shifts were not great at that time. So, we put systems in place to make sure that, people would transition care in a detailed way so the receiver knows exactly what they're dealing with when they assume responsibility of that patient. Supervision is a big issue. For me, it's an extremely big issue. I'm completely against putting the ultimate responsibility of patient care on trainees. The attending physician whose patient is admitted under their name, they are the ones to assume full responsibility for care of patients, and professionalism, obviously, which is a big thing also. So, the sponsoring institutions engage residents in the use of data to improve systems of care, reduce healthcare disparities, and improve patient outcomes. Now, how about UME? In terms of UME, the LCME requirements for accreditation now, which I know that you're in the process, we are in the process also where I am now. Our visit is going to happen in 2026. So we're preparing for it already, and we're doing all these mock preparations in place. So the curriculum to medical students basically has to help the students to understand and learn diverse, meaning that not all patients perceive health in the same way. So the students have to be educated that the perception of health is different to different people, maybe different races, maybe genders, maybe. So we have to make that assumption that we have to be responsive to how our patients perceive health or in a good status. Again, the second principle is basic principle of culturally and structurally competent healthcare. Speaks for itself. And obviously, a big one here is inequity and disparity in healthcare. We all try to avoid it. We all think we're perfect. We all think that we provide the same care to all patients, irrespective of who they are, where they came from, what their socioeconomic status is. Still, there are systems in the United States of America today that has disparity in care and disparity in access to care to patients. And we all have that responsibility. And it's extremely important that our medical students recognize it early on so they can help fix it when they go into practice themselves. And also the knowledge, skill, and core professional attributes needed to provide safe, effective, and timely care in a multidimensional and diverse society. Again, it speaks for itself. It's that awareness of where you're practicing, who you're providing care to, how to provide effective care, safe care, and professional care, and to learn the skill to provide the care that patients are seeking from you. The last item I'll cover is AI. AI is a hot commodity. Everyone is talking about AI. Everyone is talking that AI in 10 years will take over the way we provide care to our patients. So what do we know today? 75% of healthcare companies are already experimenting with generative AI, according to the Deloitte Center of Health Solutions. So it's happening already. Many healthcare professionals are adopting AI to summarize research, clinical notes, and to aid in diagnosing patients. The simplest example I can give you is reading CT scans, reading chest X-rays, evaluating retinas and making a diagnosis if a patient has a retinopathy or not based on patterns and so on. In research, obviously, it's more commonly used now. Certain gene deletions or additions and their impact on the risk that patients would have for a particular disease. And I have an example of that in a second. I just want to make sure that we all know that AI actually started back in 1942, people started working on AI. So it didn't happen yesterday. It started in 1942. It became hot in 2020 and extremely hot this year. Everyone is talking about AI. In Davos, in the economic summit that happened a few weeks ago, apparently 90% of the talks had some AI component to it, and healthcare was part of it. And, case in point, you have the CEO of Microsoft says AI is perhaps the most transformational technology of our time, and healthcare is perhaps AI's most pressing application. Tim Cook, also from Apple, he says, healthcare is a business opportunity. If you look at it, medical health activity is the largest or second largest component of the economy. Google said the same. We think that AI is poised to transform medicine, delivering new assistive technologies that will empower doctors to better serve their patients. Machine learning has dozens of possible application areas, but healthcare stands out as a remarkable opportunity to benefit patients. So better get on it yesterday. It's happening. We all have to learn it. We all have to use it. We all have to get comfortable with it and partner with it also. So the implementation of AI in healthcare is almost happening at 3 levels. Machine learning, which is the most basic use of AI. You enter data basically into a computer, and then the computer would reach a correct diagnosis based on the data that you enter and based on what's been put in place to make that diagnosis in the system itself. It will help in decision making. Deep learning, it's more complex. It has its own neural networks, for lack of a better term. So it can actually gather information from multiple sources, make sense of it, and make a diagnosis based on it. So it's not only one unified source of data, multiple sources of data. It could be pathology, it could be proteomics, genomics, and they'll make a diagnosis with it. And natural language processing, this is the most compelling one, which probably we'll see in probably 7 to 10 years. We teach a machine to understand, interpret, and also basically speak back, generate language to you. And that's the scariest one of all. So what are the applications now for AI that we're aware of? Obviously, new drug discovery is one of them. You all hear about it. Synthetic data, which is basically you take a population size set of data and then you make sense of it and you apply that learned knowledge into a management of a certain population in a society. Precision medicine that will take genetic information into consideration, environmental conditions, so even socioeconomic conditions, to determine the benefit of a certain intervention. And then the integration of data from multiple sources. You have the wearables, the social media, AMR, and all the omics, the proteomics, the genomics, glucomics, all of them would actually predict the trajectory of a disease in a patient. Efficiency obviously is improved because you're feeding info into a machine and then you get tons of data out of that. And so it's going to become an ideal population tool because you can feed in a lot of data and then you can have population or results that are applicable to a population in general, not only to an individual. You can predict the risk of that population to develop a certain disease. You can tailor preventive therapy based on the substrate in that particular population and allocate resources accordingly. I'm going to skip these. I've kind of covered them, but I just want to talk a little bit here. You know, the future of AI, we can have an all digital consult. Basically, you have a consult to a biomedical version of the patient. So you can create the patient substrate, if you will. You can test the effectiveness, the safety, and experience of an intervention in the digital environment, and then take it to a patient, which is extremely. This is a game-changing thing. Also, obviously, we're doing it now, but we can do it at a larger scale to use genetic information to personalize cancer gene therapy to patients. And like I said before, you can put the patient profile, including all the omics, and find ways to treat them in a way to affect the biology of the person that you're dealing with. So you can affect their own intrinsic biology, if you will. An example of machine learning, I put this slide here. If you look at the mutation, 0 mutation, so -10, -20, -30 is a deletion. 10, 20, and 30 is an addition to a gene. So based on a certain deletion, you can predict a population of patients would be at risk for hypertension or depression. And based on an addition to a gene, you can predict the risk of Alzheimer's disease or breast cancer. And that's fascinating to me. So this is an impact on a population, a whole population. Obviously, like anything else with AI, there's a lot of concerns about privacy, bias, who's going to have access to it, what databases are put into AI, and what information then you get out of it based on these databases that you put in, and affordability. Again, these are things that we have to start thinking about yesterday. This is mainly for the medical students and residents. If any is here, I think no one takes medicine, thinks it's easy. Medicine is difficult. Errors are inevitable, but they give us a tool to improve our skill as physicians. The goal of quality improvement is not to criticize, but to profit by sharing and examining experiences and ultimately grow and change. And the future of medical education and the delivery of healthcare will be tied to quality assessment and improvement in the future. So we better get on board, better have put the quality measures in place, because these are things that are happening or happened already if we haven't caught up with them. This is just my own summary of how cases that are identified with quality issues are handled in healthcare systems. I'm sure all of you are familiar with how these processes happen. They vary in different institutions, but these are the elements that get into play when an incident or an error happens. Risk management, case presented to M&M, look for change in the processes and the hospital system, look at safety, look at quality, do RCAs on these issues, and implement system change accordingly. For physicians, obviously, as I mentioned before, education, performance improvement plans, peer review, and the med exec committee sometimes interferes just when you have egregious events that require a higher level of intervention, if you will. All right, so, the next steps, as physicians, we're familiar with the principles of the Hippocratic Oath. Physicians should always strive to provide the best quality care without the possibility of an extra financial reward for high quality. The idealistic goals for our oath can be obscured by the realities of daily practice. Patients deserve the best, like our family. And I'll stop here. Yes.
Thank you for that great talk. It covered like everything, like literally everything. And you seem to be very knowledgeable on the AI. I was just curious, have you heard of how insurance plays into this, whether AI can help insurance kind of be more equitable? And also there's all this pre-existing drama, for lack of a better word, with insurance. Will this affect that also?
I think so. I mean, this is the field that's still in its infancy, but all of these discussions, at least from my standpoint, I think they're happening as we speak now. And, things would become more defined, I would say, probably in 3 years or so from now. Because, if you will, we're laying down the foundation for use of AI in medical care. Implementation would happen, I think, in certain medical schools and medical centers as a test sites or beta sites. It will become probably more abundant or prevalent or available, I would say, probably in 3 to 5 years from now. So all of these discussions, from what I hear, they're happening as we speak. And specifically, when you look at population medicine, what's the impact of that on insurance companies, on insured patients? You're going to be doing a lot of preventive medicine. Who's going to pay for it? And, if you were to tailor therapy for a particular patient, particular genetic makeup, let's say a cancer patient, you want to give him, precise treatment, then again, that's a big issue, because it's going to be costly to define that precise protoplasm that you're working with. But yes, all of these issues, I think, are happening as we speak.
And if you're online, I can't see the chat. So if you have a question, just unmute and ask.
Sorry, it was a fascinating lecture. Have you heard of AI in procedures or surgery? I mean, that seems like it would be more complicated.
Yes, so I think, you start with the robotics, and the robotics will become eventually the machines that will be taught, techniques and approaches, and I think they'll be the ones to decide on in my opinion, the best approach for a particular entity that you're trying to treat.
Have you heard that being studied in animals or anything yet?
No, I can't say that for sure. I'm aware that at MGH, I think, they're looking at applications using AI to improve precision of surgeries and abdominal surgeries, but I can't be more specific than that. It's hearsay.
The surgeon jobs are safe for now.
Yes, you are, I think.
I have a quick question.
Yes, thank you so much. That was a really interesting talk. If I could just continue the AI theme for a second. I'm a regular reader of Becker's Hospital Review. You know, it's just I'm a bit of a nerd when it comes to hospitals. So the thing that I've been really noticing over the last 18 months or so is just how many articles in Becker's have been written about big retail stores. So, you know, Walmart, Best Buy, Amazon, of course. And so do you have any comment about these big retailers moving into population medicine and as well as population health through digital health? Because it seems to me anyway that they are imagining a future where they take some of the cut that is currently spent on hospitals by bringing the hospital at home through Geek Squad. You know, so I don't know what we think about that.
You know, again. My answer would be, again, what I think would happen. I don't know for sure, but I give you an example of how these companies have stepped into population care, if you will. COVID is a great example of that. You know, all these companies stepped in and took charge in, doing preventive measures to prevent the spread of an, pandemic. So I think they're already setting the stage for it. If you walk into any one of these stores, they have now providers and they have pharmacies. And so they're trying to get into this market. And I do not know how AI would help them. I know in one aspect, they'll be helped tremendously, radiology. Because then you have AI reading your x-rays and reading your CT scans. And I wouldn't be surprised that we'll have a CVS or Walgreens with a CT scan and the machine reads the diagnosis and they tell patients, yes, no, go to a hospital, go home, you're good. Because I think radiology is the first field that is in jeopardy with AI. The machine learning will take over, will read all the studies, and I think will give you a more accurate diagnosis based on all the elements that are fed in compared to one radiologist reading a study from home.
We've had some of our students who said they want to go into radiology, and when I referred them to a physician, physicians are saying, we're trying to talk them into having a backup plan because they're young enough. We don't know what radiology is going to look like in 20 years.
Yeah, but the, in juxtaposition to that, interventional radiology is becoming very popular. So there are a lot of applications for it, and I think they will never go, hungry. Yes, sir.
Sorry, a non-AI question. One of the problems that I think we still have with errors is that they get blamed on an individual, right? And then somebody gets yelled at, somebody gets fired, somebody gets sued, and we're not actually looking at the systems as you describe. And then, we develop a culture of hiding errors because I don't want to be yelled at or fired or sued. How do we change that? How do we get places to start to look at that culture of allowing errors to be openly addressed?
Yeah, I mean, this is a multifaceted question. There are system errors. There are skill errors. There are lack of awareness errors. There are non-compliance with the guidelines errors. So all of them are different. I think when, the culture has to change definitely from pointing fingers and change from a punitive culture to a reparative, constructive culture. Having said that, lawyers are not sitting at home just praying to God. They're sitting, waiting to get a case, to chase you and find reasons so they can make millions of dollars out of you. So no matter what we do, if the ultimate fault if you will, and a bad outcome falls on the physician. Even if the system tries to blame it on, lack of system support, if you will, still that physician is liable if the bad outcome happened under their hands. Now, this is different from, say I get a STEMI. I try to open up the left anterior descending artery. And patient goes into VFib. I didn't do anything wrong. Patient died on the table. The case will be investigated. People may say, oh, had a STEMI and patient died on him. But this is where the system comes in. Like I did in Detroit in the last 2-3 years before I came to Alabama, took quality from being personal, punitive, and we had a great example of a physician basically who made a living out of these talks in the country. He claimed that the system he worked in used quality as a method to hurt his career and to demote him. And he won the case. He won $5 million actually from the healthcare system that he was working in. So that's the fine balance between, blaming the physician inappropriately and, kind of look at a collaborative approach, non-punitive approach to poor outcomes. But having said all of that, even if the system tries to, I don't want to use cover, share responsibility, the physician is always liable when it comes to patients, and this becomes a legal situation. I don't know if I answered the question. So the culture has to change. It shouldn't be punitive. No one should point fingers. Even if I did something wrong and I hurt a patient, no one should point a finger at me, say, you hurt the patient, you killed the patient, you did something wrong. We should look at things as a system. And risk management should look into things and try to kind of look at the aspects of what happened. We should have an M&M. We should have a quality conference. We should probably, the chairman has to look at the case and evaluate it and give feedback. What happens sometimes if we address things in a positive way, let's say, okay, well, I had these examples myself. I have 2 examples I'll use. One was a physician who's becoming forgetful. He's an interventional cardiologist. He'll ask for the same thing 5 times. So the tech says, this physician, I don't feel safe with him anymore. Brought him in, talked to him. That's a quality issue, right? Convinced him to kind of wrap it up. And he wrapped it up and stopped doing interventions. By the same token, I have another physician who's, for a simple PCI, he will bring 10 different tools. He will, drill, he will cut, he will do this, do that, and patients suffer. That physician, you put him on a PIP, performance improvement, and you say, show me that you went through I want you to go through the ACC SAP, read it, get the 20 hours of CME from it, and we're gonna monitor 25 cases of yours. And I'm gonna be supervising every single case. That's the approach in my mind. Now, when you have, someone bleeds and dies, and they call me to come and look at the bleed, and I don't come in to see that patient, that's an issue. That's the issue that I think the system would not be able to help.
Hey, I hate to cut us off. I know we have more questions. There are like 4 medical students out there who I think are literally going to eat me if we do not give them this drink. So thank you again, Dr. Lakkis. Dr. Lakkis will be around all afternoon. If you'd like to visit with him some more, just pop on upstairs. And everybody have a great afternoon.
Thank you so much.
Week.
Thank you.
Thank you. Okay, you're good. You've got your
Yeah.
slides. Take your microphone.